Hi, good afternoon. Almost good evening now. Great. So we'll start at 11:15, okay? Guys, let's get in our Zen. It's 2 more minutes. Can you see the PowerPoint, everyone?
Yes, I can.
Great. Good afternoon, everyone. I'm going to send this slides right after the session because I think I did 2 recaps, right? Last time I sent the GI, HEMA, and recap 1. This is recap 2, as you see it. I'm going to send it right after the session. Okay? Is that good? Great, yeah. Yes, I'm going to send it. No, there's no CV, but what I'm going to do, I'm going to share the plan. Give me a minute so that everybody joins. There's no CV. There's no CV for this exam. There's a clinical case, a clinical PowerPoint, which I'm going to post today only. I'm going to post an interactive sessions file and clinical case today. Give me some time because all this is last minute for me. Okay? I was not planning to teach, huh? But I'm going to post both. Right? Just have some patience. It's just last minute for me. Okay? No worries. Great. But I'm going to post a new interactive session file and a clinical case. Okay, so it's 5:15, right? Everybody's ready? Okay, so please, first few announcements so there is no confusion. I don't want students to be confused when it comes to my course. First of all, please see that there was clear communication. There's no miscommunication. You have it on your syllabus. You have it on your module that the topics for GI are heme and iron metabolism. A wrong PowerPoint was addressed in the interactive session. Last year PowerPoint, it was a mistake. I don't know why that happened. Mistakes happen. We got to be kind and we have got to move on. So let's see how we can get back in our Zen. So I'm going to redo interactive session for you, but that will be tomorrow at 10. So let's see what's my plan first. I always do recaps apart from your interactive session, right? I always do recaps for you. Last time, sorry. Okay, great. I'm happy to see you all too. So remember last time I did a recap on heme metabolism. Today I'm going to do a recap on iron metabolism. Please pay attention on those concepts and redo them from Dr. Panini's slide. Secondly, I want you to know, please be clear, there is no added topics in GI. It's only heme and iron metabolism. I will post a clinical case PowerPoint and a new interactive session file. So the first plan is to do recap today, and the interactive session will be tomorrow at 10. That session will be only 50 minutes, just like an interactive session. Then I will open question and answers for students. Please see, so the plan is recap today, interactive session tomorrow. Then I'll come for your whiteboard next week, Thursday, and a last exam recap that Friday. So let's see what we have today. First, also, I want to tell you, please, because students have a lot of problem, how to navigate the quizzes. Please, are you seeing my slides? Yes, please don't go into these folders or you will give me erroneous columns on the Canvas grade, which I have to delete. Please only approach your quizzes through this Canvas page. And the quizzes are open now. You see the arrows. Please don't go into these folders. That's a lot of work for me. I'm having a lot of work already. Don't add more for it. Please go only on this folder, and quizzes are, check your Canvas page for all those quizzes. They are open till November 16 because there was technical issue with combined quizzes. They are open. November 16, they will be closed, and I'm going to grade you on your online self-assessment. So please see that, okay? Secondly, I have given you recap. Somebody was asking me, is this file on the being shared with you after the session? It will be, okay? The exam review topic list and drug list is already on the share on the Canvas. I'm going to post a new interactive and a new clinical case by today, which I'm going to discuss. Interactive, I'm going to discuss tomorrow. You know your practice and online self-assessment. But let's first redo what we had. I always like bringing back. Great. I always like bringing back what we did. So let's see what is the key focus point for heme metabolism. Are you seeing my slides? Yes. Did we do B6 deficiency, first of all, which was ALA synthase? Very common students that get confused between synthase and dehydratase. So which one is inhibited by lead, synthase or dehydratase? Which one is inhibited by lead? It is synthase or dehydratase? It's dehydratase. Also, please know that history is important. When you compare B6 and lead poisoning, which one has, I'm just refreshing the last recap. I like doing that. Which one has, when you compare B6 and lead poisoning, which one has pain, glaze, potteries, batteries, history? B6 deficiency or lead poisoning? Pain, glaze, potteries, batteries. Are you thinking B6 or lead poisoning? Lead poisoning. So you get my point. History is very important. Not just paying attention on B6 deficiency, lead poisoning, history. Again, very good answer. What about B6 and lead poisoning? In which one of them ALA is reduced? B6 deficiency or lead poisoning? In which one of them ALA is reduced? B6 deficiency. So you understand how knowing every step, what they require, and that clinical condition. So are you doing B6 deficiency? Yes. Lead poisoning? Yes. And did we differentiate two porphyrias? So tell me, AI or PCT, which is purely neurological? AIP or PCT, which is purely neurological? Are you hearing me well, right, everyone? AIP is purely neurological. So should you first compare these two porphyrias? Absolutely. Which is AIP? Is the step AIP? One more thing, because students do ask me, please know that PBG deaminase is also known as, what are you synthesizing here? HMB. It's also known as HMB synthase. Both are the same enzyme. It's given in your lecture slides and sometimes students are confused. PBG deaminase or HMB synthase is the same enzyme. So was this AIP? Did I address this step defect as AIP? This step defect? Yes or no? Was this step AIP? Purely neurological. CP is both, but before doing CEP, I would advise you to compare. This is CP. Before doing CEP, I would advise you to compare AIP and PCT. So tell me, when is AIP and PCT, which is purely cutaneous? Which is purely cutaneous? PCT. So please also do the step in AIP, which is, sorry, this one, or PCT. Where is ELA and PBG accumulating? AIP or PCT? Where are ELA and PBG accumulating? AIP or PCT? AIP. So you got to know the step and the intermediates around that step. Rest porphyrias are good for boards, but I would say once AIP PCT is compared, I would say AIP CEP PCT. But boards ask any porphyria below the line, which I've also addressed. Now, I want to address this last step, which also is very confusing with the students. First, tell me, in the last step, if either you are having lead poisoning or you have iron deficiency. For example, last step, either you have lead poisoning and iron defect. What will accumulate? What will accumulate when in lead poisoning because of the last defect? Last step is affected by lead. What will accumulate? And that is measured in lead poisoning. What will accumulate?
Protopyrin 9 or 3.
That is not measured though. It will accumulate, but remember, instead of iron, what will incorporate in this now? Zinc porphyrin. So what is measured is zinc porphyrin. You're not wrong in saying porphyrin will accumulate, but the zinc porphyrin is measured. So you understand, whether it's lead poisoning or in case of sorry, I want to differentiate this step because students are confused in lead poisoning, and if iron is not available, instead of iron, what will be incorporated in porphyrin? Zinc. So zinc porphyrin may accumulate. 3 and 9 is not so important because 3 and 9 are the same. 3 series are in heme synthesis, 1 builds in porphyria, 1 is not normal. But I wouldn't ask you to get lost in 1 or 3. I'm just asking you to know the step and know what is accumulating. So there's nothing wrong in you saying lead poisoning, porphyrin is accumulating, but actually what is measured is zinc porphyrin. Do you get my point? So please understand that. So if iron is not available, or there's lead poisoning, there will be high zinc porphyrin. But I also taught you sideroblastic anemia. But sideroblastic anemia is iron around the RBC, like ringed sideroblast, where you will never see ringed sideroblast. Iron deficiency, B6 deficiency, or lead poisoning, where you will not see ringed sideroblast. Iron deficiency, B6 deficiency, or lead poisoning. Iron deficiency, B6 deficiency, or lead poisoning? Yes, iron deficiency, B6 deficiency, or lead poisoning, where you will not see ring sideroblast. Anyone? Anyone? Not B6? Iron deficiency, because there's no iron. How will iron get deposited around the ring? There's no iron in iron deficiency. So iron deficiency, you cannot see ringed sideroblast. So there is a ring sideroblast, there's zinc porphyrin. Understand these clinical ways to diagnose these defects or step defect also. So are you clear with that? Now treatment. Treatment should also be part of your learning. Always in enzyme deficiency, what do you remove? Substrate. What do you supplement? Product. What do you replace? Enzyme. Or if there is a cofactor. Is there any other modality of treatment that I'm missing apart from removing substrate, giving product?
Sam, are you okay?
Yeah, why?
Please mute
I
yourself.
said to supplement the enzyme through external means.
Okay, supplement the enzyme, I said. So remove the substrate. Let's take this step. Remove the substrate, supplement the product, replace the enzyme, replace cofactor. Am I missing any step that can also, or any treatment that can also be used to treat enzyme deficiency? Yes, inhibit the rate limiting enzymes. That is also one of the treatment. Now, somebody was asking me, very good. Yes. How does, you tell me how inhibiting the rate limiting enzyme will help AIP? Tell me. If in AIP you inhibit the rate limiting enzyme, how will you benefit AIP patient? What will you reduce? You will decrease their formation. Absolutely. Yes, you have a question? Yes, ask me.
No, I was going to respond, Dr. Bossy, that's why.
Yeah. So you are reducing the formation. You are not preventing the backup. You're reducing the formation. So don't forget that rate limiting enzymes are inhibited for as a part of treatment. And that is for both any porphyria. It is not subjective to any one porphyria. So this is a quick recap, though I will bring back tomorrow. In jaundice, we have prehepatic, hepatic, and post-hepatic jaundice. Tell me post-hepatic jaundice, which bilirubin will rise in the serum? Conjugated or unconjugated? Prehepatic, hepatic, and post-hepatic jaundice. Where would the patient get heme? Heme preparation is given. Heme, hemin, they are given. The preparation is given. So somebody is saying unconjugated. When you have a post-hepatic obstruction of common bile duct, when there is a duct problem, is it a rise in unconjugated or conjugated bilirubin? Conjugated bilirubin. So please first do normal. Prehepatic, unconjugated. Hepatic, conjugated. Post-hepatic, you form bile pigments. You have prehepatic jaundice, post-hepatic jaundice. I will request you to first compare pre and post-hepatic and then do hepatic, because hepatic is not very clear. Do first pre versus post-hepatic. So I have given you a quick recap. Now answer this question. So this is just telling you I'll just explain, there's a case who I'll share this PowerPoint who is pale, maybe have low iron, but which one is true about heme metabolism? So let's rule out one by one. ALA dehydratase require B6. Is it correct? ALA dehydratase requires B6. No, wrong answer. PCT leads to accumulation of ALA and PBG. PCT, yes. B6 is ALA synthase. Very good. I like how you corrected. Please, you can learn 5 concepts from an answer. PCT leads to accumulation of ALA and PBG. Is it true? Is PCT leading to accumulation of ALA PBG? No. So wrong answer. Massive hemolysis leads to increase in conjugated bilirubin. Is this statement correct? Massive hemolysis leads to increase in conjugated bilirubin. Is it correct? Do you think it's correct? Massive hemolysis, which is prehepatic jaundice, sorry. Yes or no? No, this is incorrect. D looks like, is it correct? For bile pigment formation, do you need to deconjugate bilirubin or conjugate bilirubin? For formation of bile pigments, urobilin, stercobilin, are you conjugating bilirubin or deconjugating? No, conjugation is in the liver. This is intestine. So in the conjugation is by glucuronide transferase. Remember, this is glucuronidase. It is deconjugating. So you deconjugate bilirubin in the liver or intestine. You deconjugate back bilirubin, intestine. So does this seem correct? Is D seems correct? Let's go to E. Lead, does it inhibit ALA synthase? Is lead for ALA synthase? Does lead inhibit ALA synthase? No. So what's your correct answer? Your correct answer is D. So you got to rule out the right answer. I will rebring this tomorrow because we will do interactive session. Now let's see what I want for iron. First of all, you should know what is microcytic versus macrocytic anemia. Please don't do macrocytic anemia. We always introduce macrocytic with microcytic. Who decides? MCV. MCV more than 100 factoliter is macrocytic, but macrocytic will come in spring 2026. So don't do that, but do microcytic anemia, right? So let's see what causes macrocytic. Okay, keep it at bay, but always compare contrast. But I want to ask you, which is the most common cause of microcytic anemia? Is it iron deficiency? We will do that right now. Does lead poisoning lead to microcytic anemia? Yes or no? Which steps are inhibited by lead? Give me the enzymes. Which steps are inhibited by lead? Ferrochelatase and ferrochelatase and just ferrochelatase, LR dehydratase. Be specific. What is accumulating because of that? Is there accumulation of zinc porphyrin in lead poisoning? Is there accumulation of zinc porphyrin in lead poisoning? Yes. Have we done B6 deficiency as microcytic anemia? B6 deficiency leads to microcytic anemia? Yes. Which enzyme is inhibited by B6? Oh, sorry, which enzyme requires B6? That's why ALA synthetase. Now I'll tell you why vitamin C and copper also leads to microcytic anemia. But please do iron deficiency B6 versus lead poisoning. I haven't given you a clear-cut paragraph or difference of their history too. When I was saying paint, glaze, battery, potteries, paint, it's lead. It's not B6. So the history is different, right? And I was also addressing the levels that are different. In a B6 deficiency, is ALA high or low? In B6 deficiency, is ALA high or low? Low. So where is ALA high? Give me two places where ALA is high. Give me two places, clinical condition where ALA is high. Lead poisoning and ALA is high. AIP, but now go back home and differentiate if ALA is high in lead poisoning as well as AIP. What's the difference? What's the difference? Tell me. Just tell me one difference. Though ALA may be high in lead poisoning as well as AIP, but where history is paint, glaze, pottery, batteries. Paint, glaze, potteries, batteries. Lead poisoning. So there will be a differentiating point. Some levels can be high in two conditions. So you got to know that. B6 deficiency, microcytic anemia, but I told you where there will be no sideroblastic anemia. Sideroblast means iron deposited around the RBC is iron deficiency. There's no iron. How can iron be deposited, right? Does that make sense? Iron is only deposited around RBC when they are not used. For example, in case of lead poisoning. For any lecture, please stick to your learning objectives. For iron, I want you to do that. First of all, iron is required for heme protein. For example, give me one example where iron is essential for heme protein. Any one example, please? Are you following my pace? Are you following my pace? Yes, is that helping? Right? Okay, so tell me which heme protein. Just give me one heme protein where you need iron and it's important for your body. Any one heme protein? Hemoglobin, right? Hemoglobin and cytochromes. I like that answer too. Absolutely wonderful. And then hepcidin is a very important regulator. Let's learn hepcidin well. People learn iron deficiency anemia. Absolutely, you should. You do iron stores, you do ferritin, they are low. You see TIBC, it's high. Iron levels are low. It's microcytic anemia. But don't forget iron overload, which is high hemosiderin and hereditary hemochromatosis. By just one slide, I will explain you all. So let's pay attention on this slide and complete all clinical application too. So first of all, does vitamin C deficiency leads to microcytic anemia? Did I say that in the beginning? Does vitamin C? Yes. Why? Because vitamin C is essential for absorption of non-heme iron. Is this reduction? Is this reduction or oxidation? Fe+3 to Fe+2. Is this reduction or oxidation? It is reduction. So vitamin C is essential for Fe+2 form. You should know to absorb iron Only to absorb iron, you need Fe+2. But to store and to transport, you need Fe+3, please. Otherwise, you need only Fe+2. So will vitamin C deficiency lead to microcytic anemia? Yes. Let's go to the normal now. What are these transporters doing? Pushing non-heme and heme ion. How is iron absorbed? Fe+2 or Fe+3? How is iron Fe+2? But storage, ferritin, you need Fe+3. So you should know ferritin. Is ferritin for storage of iron? So what is for transport, tell me? First normal, then you do iron deficiency, hemochromatosis, hemosiderosis. But first normal. So if ferritin is for, go and look at ferritin in Dr. Panini's slides. So if ferritin is for storage, what is transferrin for? Transferrin is for what one? Transport, but in both the forms you require Fe+3. Now let's see, Fe+2 is formed by vitamin C, yes or no? Is Fe+2 formed by vitamin C? Yes, but who can form Fe+3? Do you see hephaestin? Students are commonly confused between hephaestin and hepcidin. They are two different things. Please don't confuse yourself. Hephaestin is membrane bound, responsible to form what? Fe+2 or Fe+3? Are you seeing here? What is Fe+3? What is the other? Tell me in circulation. This is membrane bound. Hephaestin forms Fe+3. What is in the circulation that is responsible to form Fe+3? There is something in the circulation which is not membrane bound, but is responsible to form Fe+3. Not hepcidin. It's called hepcidin though. What is else in the circulation? Ceruloplasmin. Copper containing, which is for copper transport. Ceruloplasmin also forms Fe+3, but in circulation. So again, what's the role of hephaestin to form Fe+3? Hephaestin is membrane bound. What's the role of ceruloplasmin also to form Fe+3? Not shown here, but it's not membrane bound, it's in circulation. Who forms Fe+2? Vitamin C. But now, since iron moved here, don't forget, please, this is lumen, this is in cell, and this is circulation. Now tell me which transporter is pushing iron in the form of Fe+2 from lumen to circulation. Which protein is pushing iron from lumen to circulation? Iron form of Fe+2 from lumen. Ferroportin. So ferroportin is different from hephaestin, is different from hepcidin. Please do not confuse them, right? Ferroportin is the right answer. Now let's come to the last one, which is hepcidin. Hepcidin is secreted by liver. What does hepcidin do? Hepcidin regulates what? Iron entry from where? What is hepcidin doing? Moving iron from? No, from where to where? Through ferroportin, but from where to where?
Lumen to plasma.
Lumen to circulation, yes. Lumen to plasma, lumen to circulation. Now let's look at this. How does it, first normal. When your body, HFE is the protein which assesses whether your iron stores are good. Now tell me, first of all, hepcidin is a positive regulator or a negative regulator of ferroportin? Hepcidin is a positive or negative regulator. So you know all the normal function. Now I'll ask you a question. You know the normal function that these transporters push Fe+2 in. You know ferroportin moves Fe+2 from lumen to circulation. You know hephaestin forms Fe+3. You know ceruloplasmin also forms Fe+3. You know hepcidin is a negative controller of ferroportin. You got to do all of them. First do normal, please. Then jump to iron deficiency, hemochromatosis. Now I'm asking you one thing. So HFE is different. It senses your body iron. For example, HFE assesses that your body iron stores are enough. What will happen to hepcidin released by the liver? Will it be increased or decreased? Tell me. If the HFE protein assesses that your body iron stores are enough, liver will start releasing hepcidin or inhibit hepcidin release. Increase or decrease? Liver will increase hepcidin release because iron is enough. Right? Is this normal? Now let's go to two clinical conditions, inflammation and hereditary hemochromatosis. I will also tell you what is difference between hemosiderin, what is hemosiderin, what is hemosiderosis, but we'll talk about that later. Now, two clinical conditions. This was normal. When your iron stores are enough, HFE senses that, hepcidin release is decreased. Now, let's talk about two clinical conditions. What happens to inflammation? In inflammation, there is induced synthesis of hepcidin, or increase or decrease hepcidin. Inflammation, increase, not decrease, please. Not decrease. Dr. Panini has an excellent slide comparing inflammation and hereditary hemochromatosis. I don't have it now, but we can bring back tomorrow when I'm opening question answer. But no, inflammation, hepcidin release is increased. Yes or no? Are you with me? Are you clear with that? Yes. Now let's talk about hereditary hemochromatosis. Now, hereditary hemochromatosis is HFE mutation where there's a false sensing of iron. You think that iron is low. In hereditary hemochromatosis patient, they have a false sense of iron being low. So tell me, in hereditary hemochromatosis patient, if they are sensing that iron is low, what will happen to hepcidin release? Increase or decrease? Decrease. What will that lead to hemochromatosis patient? More and more iron from? If hepcidin is low, what will happen to iron flow from lumen to circulation? Will it increase? If hepcidin is low? No, it will increase. Don't say decrease. Again, in hereditary hemochromatosis, there's false sensing of iron. You think that your iron body stores are low. That's why hepcidin releases increase or decrease because of false sensing. It will be, no, false sensing that ions are low. Hepcidin release will be increased or decrease? Decrease, because of which ferroportin activity will increase or decrease when hepcidin is low. No. Please, you got to understand. You got to understand hepcidin very well. So everybody's answering everywhere. So again, in hereditary hemochromatosis, there's false sensing of iron. Hereditary hemochromatosis patient think their iron stores are low, which is wrong. They have false sense. Because of that, hepcidin release by the liver will increase or decrease? First answer me that. Decrease. Very good. Because of that, ferroportin activity will increase or decrease? Ferroportin. Low hepcidin. Ferroportin activity will increase. And what will happen to iron? More and more iron will push from lumen to circulation. That's why hereditary hemochromatosis have iron overload. Does that make sense? You got to understand hepcidin very well in different situations, whether inflammation, whether hereditary hemochromatosis. We can do that again. I just want to bring up important points. I just want it to be a quick recap. So let's finish that. So yes, tell me who's working here. Let's do some questions. Who's working here? Give me the answer. Top here, where my cursor is. Vitamin C. Absolutely. I like that answer. Very good. Vitamin C deficiency leads to microcytic anemia? Yes? Yes or no? Great. Let's go. Sorry. Let's go to the second one. Who's working here? There could be two. There could be two proteins working here. Hephaestin. Very good. Is hephaestin same as hepcidin? Is hephaestin same as hepcidin? No. Please keep an eye. Ceruloplasmin, wonderful. Now, did they say that copper deficiency leads to microcytic anemia? Will copper deficiency leads to microcytic anemia? Yes, because you cannot transport iron. You can't do transport because you need Fe+3 form. And hepcidin is a positive or negative regulator of ferroportin? Hepcidin is a positive or negative regulator? Negative. Don't flip-flop that. Please pay attention on all these concepts. So Fe+3 is for transfer and storage. Please go and review ferritin and transferrin first before doing iron deficiency. And for absorption, it is Fe+2. Now, what is difference between hemosiderosis and hemochromatosis? Just the clinical presentation. It's just deposition. Chromatosis is beyond deposition. It also starts damage. Please know that since Dr. Panini has mentioned, this triad in iron overload is known as bronze diabetes. Secondly, people are confused. What is hemosiderin? So hemosiderin is formed in, you said hepcidin. Yes, hepcidin is a negative regulator of ferroportin. Yes. So hemosiderin is formed in iron overload or iron deficiency, tell me. Hemosiderin is formed in iron overload or iron deficiency. Iron overload or iron deficiency, hemosiderin. Very good, iron overload. Hemosiderin is actually a partially stripped form of ferritin. So do all these concepts, then get into regulation. Yes, hepcidin is a negative regulator of ferroportin. Ceruloplasmin, is it required for iron metabolism? Is ceruloplasmin required for iron metabolism? Yes. Understand that. Is hepcidin a negative regulator of ferroportin? Absolutely understand that. Let's do this question now. This is a patient with rheumatoid arthritis. So you see a kind of excessive inflammation here. Please don't memorize answer. So tell me, first, when you see inflammation, what do you think is they are pointing towards? Is there anything that is increased during inflammation? Anything that you think of? Hepcidin synthesis is induced, but still don't jump to the answer. Tell me, what is ferritin doing? What's the function of ferritin? What is the function of ferritin? Storage, iron in the form of Fe+2 or Fe+3? Ferritin, iron is Fe+. Please go and see how ferritin is formed. Ferroportin, what is ferroportin? What is it doing? It is pushing iron from lumen to cell or cell to circulation. B. Ferroportin is moving iron from lumen to cell or cell to circulation. Cell to circulation, not lumen. Oh, or no, not lumen to circulation, please. So you have to go back. That's wrong answer. First there is lumen, then there is cell, then there is circulation. Where is ferroportin? On the luminal side or the other side? So ferroportin is moving iron from lumen to circulation or cell to circulation? Cell to circulation. Please, ferroportin is not on the luminal side. Go and see that. Transferrin is for transfer. Ceruloplasmin is for iron metabolism? Yes. But in inflammation, which synthesis is expected to increase? Hepcidin. Right? Does that make sense? Now tell me now, let's do an application now. So in inflammation, if hepcidin is released or induced, what will happen to ferroportin? Its activity will be high or low? Due to high, low. So you got to understand this whole cascade, not just alone. You're not memorizing that inflammation increase hepcidin, but then what is going to do? It's going to, if hepcidin is increased, it's going to inhibit ferroportin. Its activity will be reduced. Does that make sense? You got to make that connection. Yes, you should talk about hepcidin, but also what is its effect in inflammation, in case of hereditary hemochromatosis. And yes, hepcidin is increased in, hepcidin synthesis is induced in inflammation. Yes, don't forget then iron deficiency. And hemochromatosis and hemosiderosis is the same, I told you. Or what is the difference? Hemochromatosis also is associated with tissue damage. Hemosiderin is just deposition of excess iron. But how do you do assessment of iron deficiency? It would be pain, conjunctiva. There would be changes in the nail. Iron will be low. Ferritin would be high or low. What would ferritin be? Low. What would ferritin be? Low. Ferritin would be high or low in case of iron deficiency anemia. Ferritin stores would be high or low? Low, because ferritins assess the stores of iron, and total iron binding capacity increases to compensate, just to compensate the low iron. So TIBC is high. During inflammation, hepcidin synthesis is increased. During inflammation, hepcidin synthesis is increased. So do parameters of iron deficiency, especially, and understand the hepcidin with respect to inflammation and hereditary hemochromatosis. Yes, hepcidin is increased during inflammation. So I taught you iron and a recap. If you have any question, you can stay. Otherwise, we'll come back tomorrow at 10 with the interactive session and questions. Great. I hope this helped with iron. Great. Okay, yes, Aaron, what question you have? If you have questions, you can stay. Otherwise,
Hi.